Okay. Hang on a second. My computer's being uncooperative. Okay. So you want me to start presenting now, or are we waiting for something?
Anytime you'd like to do, we're ready for your presentation, or if you want to do any discussion beforehand, that's welcomed as well. But you can go ahead and get started anytime you're ready.
Okay.
And if you want, you can send me your PowerPoint as well. I'm happy to screen share if there's any tech issues, but it looks like you got it going, so that's good.
Come on. There we go. Okay. And it should momentarily be full screen. Okay. So what this is I have a series of what I call oddball cases addressing primarily spirometry and what to do when something comes in that's a physiologic anomaly and how you can deal with it spirometrically. There's a series here. I think I made it through 2. I've got 6 that are set up so far, and so what I'm going to do is I know we made it through 2. This last one may be a bit of a duplicate, and then we'll continue on and look at some of the other ones. So the question, just as background, I do a fair number of federal black lung evaluations, all of which include spirometry. Some of the people come to see me have medical conditions that will make their spirometry abnormal. And so what I'm trying to do with these is, okay, how do you kind of fix their spirometry so that you can interpret the results based upon what the other medical condition is.
The first one because this one I can constantly, and one of the other physicians that does evaluations of these black lung patients for the employer will perpetually point to obesity as the cause of pretty much whatever's wrong with their lungs. And so I've done pretty much of a deep dive into spirometry and black lung, spirometry influences from obesity, and we'll just kind of go through this. So this is my example patient. So it was they were a never smoker. They had a BMI of 32. The FVC was 54% predicted. The ratio was normal. The total lung capacity was 56% predicted, and the RV was 88% predicted. And then their ILO interpretation was of a 1-1 QQ with no large opacity. So there was evidence for black lung on the X-ray, and then what we would normally call restrictive disease. And I diagnosed the minor as having restrictive lung disease because they have both the increased FVC and they also have a matching total lung capacity that's been decreased. The company physician said, no, this is all from their obesity. This has nothing to do at all. Nothing. Pay no attention to the black dust behind the curtain. This must all be obesity. So I went down to the library to figure out what actually is the documented impact of obesity on spirometry. Now, so my question was, how do I correct for obesity on spirometry? Just like if you've seen, I think case 1 is lobectomy in this thing. So how do I fix my spirometry results? And my first question, does obesity impact FVC, FEV1, or both? And how big of it, and how much obesity is necessary to really see this impact? So the problem in the world of medicine is the super early literature. Well, okay, so this is 1810. Now keep in mind, back then medical literature was basically a series of stories. So if you saw a patient that was unusual, you would write in a little note to your regional medical journal, and they would publish it to share your experience with other physicians. So they talk about a country tradesman, age 30, of short stature and naturally of a fresh, sanguine complexion, and very fat, applied to me for assistance. He complained of a perpetual drowsiness and inactivity. His countenance was almost livid, which means dark bluish gray in color, such degree that somnolence attended him that he could scarce keep awake whilst he described his situation. In other aspects, he was well. And so that's the first description of what we want. A couple of, I hate to call this medical literature, but that was in the medical literature that was named Pickwickian syndrome, and it had to do with an increased girth accompanied by loss of respiratory reserve and ventilatory function. There are some clinical features that were listed with Pickwickian syndrome in this literature, in the medical literature: marked obesity, somnolence, twitching, cyanosis, periodic respirations, secondary polycythemia, right ventricular failure, and right ventricular hypertrophy. Where does this go back to? Well, we're back to this is the less medical literature. Is Pickwickian syndrome per se goes back to the Pickwick, the posthumous papers, the Pickwick Club, a book written by Dickens way back when. And they talked about Joe, character pictured on the right, who was so somnolent he would fall asleep while standing up and even knocking on a door. And they called him a bunch of different things in that movie. Young Dropsy and Young Opium Eater were actually nicknames used in the book for this person.
Hey, Carl, I got a quick question.
Sure.
Go back a slide. Well, going back to the slide where you listed the clinical features, you're talking about 19th century literature. The only way they would know that he had right ventricular hypertrophy would be at autopsy, right?
At that point, absolutely correct.
Okay.
But wait, let me go back for a second, because this gets a little bit confusing. So let's see if I can get my computer to be cooperative. There we go. So 1810 there was no testing for anything, right? And so the 1810 story would have only been an autopsy, but they just described the condition. They didn't talk about the pathology. In 1956, come on. In 1956, they would have had cardiograms.
Ah, okay.
So this is based upon the testing they could do in 1956. This would have included a cardiogram, would have included a blood count.
Okay. Thank you.
Stuff like that. Okay. So in the posthumous paper, meet Joe, who falls asleep pretty much all the time. And the case report that was in Burwell's article was of one guy. He's 5'5", 263 pounds. That makes his BMI 43.3. And he gained about 60 pounds over the prior year, the cause of which is not discussed. And so they talked about cyanosis of the face and nail beds, but no clubbing of the fingers, very somnolent, and fell asleep in the middle of a conversation. He was otherwise relatively okay. They hospitalized him, because you could do that back then, on a strict 600 and 800 calorie diet, and he quickly lost about 44 pounds of weight. And for reasons known only to them, but not a bad idea for the purpose of descriptive science, they did lots of collection of data on respiratory function. Maybe they just got a spirometer and needed to figure out what to do with it. So this is the data for this article, and you can see that from his initial admission, or at least week 1, there is a marked improvement in vital capacity, a decrease in weight, an improvement in the maximum breathing capacity, which is I think what we would call TLC. The arterial oxygen saturation went up, the CO2 went down. I mean, these are big changes that occurred over a couple of weeks during weight loss. So that's, I'm not saying that this didn't really happen. I think it really did happen, but they're marked changes. There's just a teeny tiny little problem. And its BMI went from 43 down to 37.8. So we're still in the obese range, but we're less obese. The problem with this is an N of 1. So we've based an entire syndrome on one guy back in the 1950s. So what did he probably really have? He had what we would now call obesity hypoventilation syndrome, um, obesity, daytime hypoventilation, and sleep disordered breathing. The official, I listed the official criteria there. The way I think of this is it's really profound sleep apnea that was so bad that the person couldn't even correct their ABGs during the day. So they were still hypercapnic and hypoxemic, hours after they'd awoken, because they just couldn't correct because they were so exhausted and they couldn't stay active long enough to actually fix the blood gas. That's what I think of what he really had. So I went into the literature and looked to see what I could find as far as reviews and data on the impacts of obesity on spirometry. If you follow some of the other black lung people, Ash K. Sood, who was the article of this literature and several others on this topic, went and looked. This is kind of a meta-analysis of what the literature shows, and the ones I've highlighted, you'll notice that the vital capacity may be normal or slightly decreased. The FEV1 is normal or decreased. The ratio can go anywhere, up, down, or sideways. But the total lung capacity will remain normal even in a person where it's due to obesity. So when you start seeing the total lung capacity being more than, when it says slightly decreased, like that would be like 90 or 90s, maybe 80% predicted. When you start seeing the total lung capacity going down, that's something you need to pay attention to, as suggesting that it's something more than just their obesity. A different article, still different mention, still article by Dr. Sood, is they followed a bunch of morbidly obese people after across they're getting bariatric surgery. And so there's a couple of things that you need to look at. So when people lose weight, the residual volume gets better, their total lung capacity gets a little bit better. But if you look on this graph, it went from maybe 90% predicted to 125%, 105% predicted. It still stayed around normal, the total lung capacity. The residual volume is the one thing that is definitely affected by obesity. And I just want you to know their starting points. They weren't very decreased, even in patients so morbidly obese that they were eligible for weight reduction surgery. So Hankinson who is the developer of what people call variously the Hankinson equations or the NHANES spirometry equations. When he did that, he looked at height, weight, BMI, and a bunch of other things, and he concluded that there was really no improvement. That height and weight were about equal in predicting, and he was looking at total height. BMI didn't seem to help them much. They found they used height because you can do height in somebody. Excuse me.
Bless you.
Thank you. You can more easily measure the height, and that they determined that it didn't really add much to the statistical evaluation of the data to use BMI or weight, and so they elected not to leave that out. So here's a study of pre-op bariatric patients. Bigger study, 229. They did spirometry, I think, as part of their anesthesia evaluation. And these patients started with a BMI of 57. And what they found was most of the people, even with a BMI of 57, had normal spirometry pre-op. The interesting thing they found was obstruction in about 29% of their people. Now, their definition of obstruction was they used the lower limit of normal, and it hadn't been seen previously. They did not find any relationship between body size and spirometry except for the small decrease in the ratio. So when you look at people with different BMIs and what their PFTs are, this is a separate study that was done by Jones and NISQ, I'm going to guess. And you can see what I look at here is the total lung capacity and the residual volumes. Let's go across the TLC column, and you'll notice that when you get up to 35, you start seeing some 30-35 numbers, start seeing some decreases, but you're still well in the normal range, even for people greater than 40. If you go up to the vital capacity, now this is in Europe, they use a slow vital capacity, whereas we use a forced vital capacity, but they both at the end of the day should give you about the same end point in vital capacity. And you'll start noticing that there is some drop off in vital capacity as you go to higher weights, but but you're still in the 90% range until you get above 40, a BMI of 40. So there's not a lot of impact, even with what we would consider morbid obesity or profound obesity when you get above 40. The residual volumes, however, do decrease, and the ERV, if you look, drops precipitously. So just be prepared for that. The FRC and the ERV towards the bottom drop precipitously. The interesting thing to me also is the DLCO gets better. The more obese you are, the better your DLCO is, which is sort of an interesting finding. And I said the ratios are better for the obese. Notice the ones that are now circled in purple. The ratios get better, as does the DLCO in people who are morbidly obese. So, in somebody you should never blame somebody's low DLCO on obesity. That's doing it incorrectly. And we talked about the vital capacity, and I forgot these said circles on them. So the next thing is I looked at, this is an article, a different article, where they looked at changes in different things. This is across a whole bunch of studies. And the key thing is that the vital capacity decreases in 2 out of 4 studies. So it's half the time it goes down, what they consider to be an important amount. The functional residual, the FVC, decreases in 4 to 7. So it's still about half. But there's some studies where the vital capacity went one way and the FRC went the other way, which is kind of confusing. So that's another, that may have something to do with like the impact of obstructive disease, because in really bad obstructive disease, you do a slow vital capacity and you may get better data, as I'm sure most everybody is aware. The FEV1 went down to 6 out of 9 studies, so that's actually more than half. So for obesity, Pickwickian syndrome or obesity hypoventilation syndrome really does exist, but CPAP, now something that's available, will help treat most of those people. Obesity does not in and of itself affect the normal pulmonary function test, the FEC, FEV1, the ratio, until you get the BMI over 40. You may see subtle PFT changes, but you may also see even an increased FEC or a slight decrease in FEV1. But obesity does impact the ERV, the FRC, and to a smaller extent the total lung capacity. So just be aware that there can be some impact, but not on the ones that we typically use. Okay, so my take home is that if the BMI is less than 40, there's probably almost no impact on spirometry. So if you've said, hey, this patient's changes are probably because of their obesity, if their BMI is not over 40, you may be time to go back and look at that again. And we do know that weight loss can improve PFTs, maybe even make the people super normal. And always remember, obese patients can have lung disease too. So don't write off very much of their changes in common testing that you'll see to obesity until it gets to be a pretty big BMI. So back to my case, we started with an FEC of 54% predicted and a normal ratio. So my conclusion is the literature really does not support any noticeable impact on spirometry from a BMI of 32, which is what our patient had. And so his FVC changes are completely due to his, lung, some other disease other than obesity, like his black lung, for example. Next topic, pneumonectomy. So this patient, I had a patient that had a pneumonectomy for lung cancer. I saw him for black lung evaluation about 6 years later, so he'd completely recovered from the procedure. And at that point, his chest X-ray was a 1-0 of Q/S size opacities. And so my question is, how do I figure out the impact of the obesity on his pulmonary function? I'm sorry, of the pneumonectomy on his pulmonary function testing? Found a couple of articles, and they showed, what was interesting was they did show differences in right versus left. So about a 40% decrease for right pneumonectomy and 34% for left. That makes sense. You have whole another lobe on the right. FEV1 had decreases, but they were more similar. They're both about 40% change. So what I like to do if I have to do one of these corrections is I like to adjust the lower limit of normal rather than try to adjust their numbers. So I'm not making up a new number for them, changing the cutoff. And so I would just take the lower limit of normal, the 3.43, I'd multiply times 58.5%, which is what I expected to get 2.01 liters. And then when you compare, he would then be normal pattern because he's well over 2.01 liters. That's the way I like to do it. You can do it the other way around where you adjust their numbers, but I think this is easier. I've never changed their number. I just changed what I'm comparing it to, which I think is, at least for me, it's intellectually cleaner. Next case is stroke. This is an 82-year-old minor, 32-year tender underground. He was a never smoker and came in with what I called moderate left hemiplegia. He did use a wheelchair. He was cognitively intact and cooperated well, but he was pretty deconditioned because of being in a wheelchair. And it took 3 of us to get him from his wheelchair up onto a stool to get the chest X-ray, just to kind of give you a reference for how disabled he was. And so this was his results from spirometry. He had the FVC was 49% predicted, FEV1 of 56% predicted. The ratio was 71%. So that would normally be interpreted as let's see, severe restrictive disease. And it really didn't really change much with bronchodilator. This is the actual graphs, and you can see they're pretty good effort. Maybe some glottic closure, but not severe. So I went back to literature for this one. There's very little literature on strokes and their impact on spirometry. I think the underlying problem is that every stroke's a little bit different and its impact's a little bit different, and the disability after the stroke is a little bit different for each person. What the only literature I was really able to find was literature across some treatment or another, but they just compared an individual to themselves. So they never talked about, they never give actual values. They would say, the mean pre-treatment group, the mean for our 25 subjects was an FVC of 3.2 liters, and they would do whatever their thing was, say, okay, after we did our procedure, the mean improved to 3.65 liters. So it didn't really give you a number you could compare to normals. I did find one, whoops, let me go back. Okay, there's one study that did pre-treatment and post-stroke spirometry that actually compared people to normal. So I can give you some information about that. They found the FVC and FEV1 were kind of like low normal, but they had huge standard deviations. So and the number was only 21. I would be very careful in adjusting this. I don't recommend correcting for post-stroke because it's just too variable. A lot, and to just my recommendation is don't correct for stroke. Just acknowledge that it's a problem. because I don't think the literature is out. There's enough literature available to make a good recommendation. What about Parkinson's disease? This is one I just had in the last week or two that I had to deal with. Parkinson's disease can cause dysfunction to the chest wall, and both with weakness and also rigidity of the muscles, and can limit forceful respirations. So that you can see decreases in FVC, but usually the ratio will be preserved. And usually it shouldn't have minimal to no impact on lung volumes because that's a slower test. It does vary with disease severity. And I learned, I didn't even know this, there's a scale called and I'm going to get, there's an H-Y scale. I'll figure out what that stands for in just a second, that you use to assess disease severity. And then you can compare that to look at how it should impact their spirometry based on how bad their disease is. So here's the study. It's the Hone and Yar staging scale. And you can go, so it goes like the 1.0 goes from unilateral involvement or action involvement, which shouldn't really affect spirometry very much, down through, severe disability, but can walk or stand unassisted, all the way down to wheelchair bound or bedridden unless aided. The patient that I described would have been a H&Y category 5. Okay, so because he was wheelchair bound, and it took 3 of us to get him even to standing. So we're even to sitting on a stool. So for the X-ray, so that would be his level of pretty profound impairment. So here's what they did spirometry, and they're all in different places. The one to focus on is the upper left-hand corner, which is the vital capacity. And if you just look at the graph, you can see that the vital capacity decreases significantly. So their HMY1 people had a vital capacity of maybe 3.1 liters, and their HMY5 people had a vital capacity of maybe 1.5 liters. And if you look in if it's hard to read the graph, I think it's zoomed in on the next screen. But they describe that as a let's see, between 1 and 5, a 1.64 liter decrease in their vital capacity. You'll notice also that the ratio, if you look in the right upper corner, the ratio doesn't change across severity. So it affects FVC, but not really FEV1. So the ratios stay consistent all the way across. Doesn't matter how bad their disease gets. So when I zoomed in, you can see that okay, so my category would be go backwards. There we go, that one. So my category would be an HY5 patient, and I need to compare him to an HY1. Now, one of the things you have to know from the text portion of this article is that the HY1 patients, so they had a little bit of Parkinson's disease, but it was unilateral, were not statistically different from normals. So when they compared them, they're the same as normal people. So what I can do is I'm comparing, if there's a middleman here, but I'm comparing category 1 to category 5, and then I'm assuming category 1 represents normal. And you can see there's a 1.624 liter decrease between category 1 and category 5 for the FVC, or vital capacity. Then now I need to do some math. So my patient had a measured FVC of 55%, FEV1 56% predicted, and a normal ratio of 82%. And his lung volumes were decreased slightly. And so my question was, is this due to his spirometry? I'm sorry, is this due to his Parkinson's disease or some other cause? Back to doing my math. And so if you kind of work it out, the average remaining, if I take 3.1 liters, subtract 1.62 liters from it, I end up with about a 48% predicted that would be the normal for this person based upon the impact I would expect for this person based upon just their Parkinson's disease, which is a pretty significant disease decrease. I mean, that would put him in the very severe category for spirometry as his starting point. So this patient was at 55% predicted for the FVC. So he's actually doing better than I would expect him to do purely on the basis of his Parkinson's disease. And for this guy, I can't definitively say that there's an impact of anything else on his breathing other than his Parkinson's disease, because it's so profound. I think that all I can say is that, I can't say there's more, that it's worse in respect with Parkinson's disease, because he's actually a little bit better. Any questions on any of that stuff?
Grace Ann had a question. It's in the chat.
Oh, okay. Hold on. See if I can get the chat going.
She was asking what the N is in the SNOOD study.
Oh, sure. So N is just how many people were in the study. Let's see. So in the SUD study, let me see, can I get my computer to let me go back to SUD? There we go. I'm not sure. I'm sure I knew. I probably knew at the time. I don't think I know on that particular study. The thing that I can't remember is some of the stuff is what Sue did was a kind of a review of all the literature up to that point, and that may be one. Because sometimes he snips like results out of another study, then puts it in his kind of overall review. This may be one of those. I don't remember the answer to your question. I know that this particular one, the N is this is across all of the studies that he's all a bunch of stories. It's kind of a meta-analysis of other people's studies.
But Carl, my question is, I mean, often when it's a review and you combine studies, you do a forest plot or something. I just don't know what his methodology was that he, because it's one of the things you're relying on. So I was just curious about that.
Yeah, so I think the other one like that. This next one. This is not from his study, but it's the same kind of an analysis, which is he took in multiple studies. I understand the question. I don't remember the answer, is what it comes down to. I want to say he looked at, there are probably 30 references, but again, I'm making that number up. I don't know.
Okay, it's hard to evaluate though how much you can rely on it if you don't have the equivalent of a forest plot or something, because then it becomes opinion.
Yes, what he was doing was consolidating opinions.
Yeah.
And one of the things that's really hard is it's in a lot of the literature. I'm gonna call this specialty literature, meaning that it's kind of obesity within spirometry. Everybody does it a little bit differently for probably some slightly different purpose, and so you can add them all together, but it's not there's among your 30, or is it if he's got 30 studies he looked at, among those 30 there's going to be different methodologies, and different approaches and different ones. So you can't truly, you can combine the results, you can't combine the people and add them together in a different analysis, if that makes sense.
Carl, the further question is, when you present this evidence to indicate that someone who is obese is in fact eligible for black lung, how persuasive is this evidence to the examiners?
I don't actually know the answer to that. I almost never know what the final outcome was for the patients that I evaluate. But because what happens is like I'm a little cog in this big machine, and so they come to me for the evaluation. If additional information comes in, I'll get a request from the Department of Labor to do a supplemental report, and I've created a 4-page review, taking in basically pretty much the same information that I just presented, that I say, please see my review of this topic below, and send that back in. I think it's pretty persuasive as far as trying to write everything off to obesity. a lot of times what the impression I get is that the people doing the evaluations for the mining companies kind of are throwing spaghetti at the wall and seeing what sticks. And so I can make the obesity ones slither down the wall and that one falls off. But I don't know, at least I think that's what I'm doing. But I rarely know what the final outcomes are. I mean, it's kind of a negative thing, because I guess what I could say is that if I see them, if they come back for another evaluation, then they probably didn't get benefits. But other than that, I don't have any way to know. Any other questions?
Thank you so much, Dr. Warrens. We really appreciate this so much. And I know this is sort of on short notice as well. So extra thank you to you. Any other comments, questions from the group? Dr. Stansbury, I saw you unmuted. Did you have a comment?
I think, can I share my screen? That was a very great talk, Carl. One thing to keep in mind, this was from a talk I gave in Texas a couple years ago. Can you guys see that? One important thing to consider, there's you're absolutely right. When you just look at the whole obesity kind of cohort, there's not that big an impact on pulmonary function. But this was just an interesting review they did probably 10 years ago, where they looked at eucapnic obesity versus, folks who actually met obesity hypoventilation syndrome criteria. You can see the differences in pulmonary function tests there. With the obesity hypoventilation folks tended to have some, markedly reduced values. And there's more to it than just, PFTs. There's the sleep disordered breathing component, which you talked about, bicarbonate compensation, some impairment in respiratory mechanics. And then they think there's even probably a hormonal component where the respiratory drives affected, because when you think about it as at a basic level, your CO2 level is kind of the equilibrium between how much CO2 your tissues are making and how effectively you ventilate and breathe it off. So if you're really obese, you have more tissue, you're making more CO2, and you compensate mostly by having a little bit increased baseline respiratory rate. But for whatever reason, there's obese people, not everyone with a BMI of 40 gets obesity hypoventilation, right? It's probably somewhere in like the 15%, 20% range. So something happens where, the subgroup just kind of falls off the wagon. And, one of the thoughts is that, leptin, which is a satiety hormone, is actually a fairly strong respiratory drive hormone as well. So in obese people, it's really elevated. And one thought is, do some people get quote unquote leptin resistance, like insulin resistance in diabetes, and they don't have their response to compensate for this extra CO2 isn't effective, and it falls off. So one thing I always keep in mind with these folks is, when you look at the BMI cutoff, it's 30 per the ATS guidelines. But once you start getting in that 40 range of BMI, that's where you really start seeing this uptick in people. And, no one does ABGs anymore, but a pretty good kind of screening test is a serum bicarb, which you get on your basic metabolic panel. And then the other thing I'd, kind of call your attention to is the oxygen saturation nadir. When we see this in the sleep lab all the time. I mean, these people like desat to the 60s. It's amazing. But if you, did an overnight oximetry on one of these patients, and you're like, I mean, was this artifact? I mean, how they could just get so hypoxic? That might be someone you have to, consider this diagnosis on. And it is a really important diagnosis, because they get severe pulmonary hypertension, RV failure, and die if you don't do something.
Thank you, Dr. Stansbury.
Yeah, I absolutely agree. I'm not. I think that these are all very important medical conditions. I'm not trying to take anything away from those. What I was really looking at was kind of my starting point was people blaming like bad spirometry on
obesity.
on mild obesity.
Yeah.
My case, the guy has a BMI of 32.
Yeah.
Shouldn't see much at 32. When he gets above 40, you need to at least think about it.
Yeah.
But yeah, the obesity hyperventilation syndrome is a real thing, and it can be treated. And I'm not taking anything away from that, but I really appreciate that, because I've not done the deep dive. I'm not a sleep medicine person, but that was really interesting what you just shared. Thank you.
And actually, I think that case by Sidwell you talked about is kind of interesting. That guy came to the doctor because he was a big poker player, and he was in this big poker tournament with like $100,000 in the pot and had a royal flush and fell asleep and dropped his cards on the table before the game was over and lost the pot.
That's a great example of why anecdotes matter.
Yeah.
That's not in the. I actually read the original article. I don't think that was in the article, but that may be the history around the article.
Yeah.
Very cool.
Hey, I want to take a stab at why this matters, because I was kind of thinking, well, as you were presenting, I heard you present this a couple of years ago, Carl, and it made a big impact on me because, I had been, like lots of people, kind of routinely attributing mild restriction to obesity. I'd always look at the BMI and I'd say, okay, well, there's the reason why. And then I heard you present this, and that was a big, that was really significant, because it meant if you were right, I had to do something different. But then thinking about, well, okay, does this matter other than in determinations of work-related disability? And it seems, so I'd be curious what Rob and others think about this. And to me, so for, say, a primary care provider who's out there, or an internist, general internist who's out there in a rural hospital, and his or her job is interpreting spirometry, and they're putting these interpretations on, and then the providers who get the reports, who are even less, one of our big concerns is that providers often aren't confident looking at spirometry themselves, so they depend on the interpretations that they're seeing. And I think, so what I would say is, yeah, it matters, other than determination of work-related impairment, because it means that the providers will overlook what could be clinically early significant interstitial or restrictive lung disease that there might be interventions for. And I'm curious if anybody, Rob, there's so many causes of restrictive lung disease, and so many seem not amenable to treatment, especially curative treatment, that I guess, number one, does that sound right to you? That's why it matters. And number two, what would be a clinical example of interstitial lung disease where treatment would be delayed because of this mistaken interpretation?
Yeah, so, and this even comes up, we get referrals from this actually a lot. And, the big question we ask is, do we need to do a high resolution CT on everybody? Because this is actually not, this is a fairly common finding even in West Virginia, right? Sometimes we'll look at the ERV, and if it's really down, there's a pretty good data that suggests that, maybe that's what you're seeing when the ERV is down. You can feel a little more confident with obesity, driving some sort of mild restriction. If you're just looking at spirometry, and I always try and get the lung volumes if you can, because remember, you can't really diagnose restriction based on your FVC. You really need a total lung capacity, and that's a fairly simple test to get people to. But you know, it's something we talk about all the time in clinic. We need to do, you know, a high resolution CT on all these people because of early ILD. And you know, I'm trying to think of a case where we were like, well, maybe this just isn't the obesity, and we got the high resolution CT, then we don't see anything. You know, I can't think of one where we actually caught an interstitial lung disease.
Okay, my other question. Okay, and so I guess my other question, I'm thinking about, what do you teach the residents and the fellows? Because I think, correct me if I'm wrong, it's still pretty conventional belief and a conventional error in interpretation, assuming that Carl's position is correct, to attribute mild restrictive lung disease with TLC to obesity. Is that what people are finding? You know, out there, Aaron and Sheila and Stacy, maybe Leslie. I'm assuming that you're seeing this interpretation, that this restriction is due to obesity. What are you trying? Are you working hard to correct that misconception, Rob? And how do you teach this to the residents? Because they're hearing people all the time attribute it to that.
Mm-hmm. Yeah, again, you know, we pay attention to the ERB as maybe something that's supportive. I can't remember what it was, but I think can't remember what the cutoff is now on my head. But if the ERB is like really low, that suggests that maybe obesity is playing a larger role. Expiratory reserve volume. But you know, a lot of times we, you know, we'll say something like some suggestion of restriction, maybe obesity, and the classic hedge clinically correlate, you know.
Okay, thanks.
Thank you for the questions, Dr. Doyle. Any
But
other
there's
thoughts?
some tough ones, like even stroke and Parkinson's, you know, we get PFTs on them, and sometimes they can't even, you know, perform the maneuvers and maintain a seal on to do the spirogram. So those are very challenging patients.
Yeah, where it gets hard. It's if the person can't, if you get no result, then that's actually easier. The problem is when you get a result, because then you have to interpret it.
Yeah.
You know, if the technician just says, you know, patient was never not able to maintain a seal, I can't tell you anything from on that test, and that one's actually easy. But when I have a valid result, you know, it's repeatable and all that stuff, but it's just really low. And I think it's, you know, that's that has a lot to do with it. One of the things for our patients for the black lung evaluations is the patient is motivated to have it sounds crazy. They think they're motivated to have the worst test possible, but what we explain to them is they have to have valid testing, because if it's not valid testing, it doesn't get us anywhere. And so we have to encourage them that way. But they you know, they're there for the benefit to claim benefits, and we have to tell them, if you don't have valid spirometry, we can't do anything with this. You know, so follow what we're trying to do the best you possibly can, and we should get valid spirometry, and then we can assess it.
You know, part of their evaluation is their kind of physical limitation, right? Like what they can do. Is that true?
Sort of. So part of what we do is we place an A line and actually do resting and exercise ABGs. So I actually get kind of what they call doing like cardiopulmonary stress test. And so I can say this person was able to demonstrate, you know, 7 METs on the treadmill, and this is what happened. Their blood gases, you know, were physiologic or anti-physiologic or whatever happened. So that's part of the assessment. So I get that. We get full pulmonary function tests. And then there's also a history and physical and a chest x-ray. Although the physical is pretty limited. It's, you know, that they're not in heart failure, plus, you know, heart, lungs, and fingertips.
Yes, so Rob, that's really important to know that these DOL exams at the best places include exercise blood gases with art lines, resting and with exercise. There probably still are some places where, and Carl, you can supplement this, where examiners are doing arterial stick blood gases. But the problem is that they have to have the patient stop exercising and do the stick, and maybe they get it right away, maybe they don't. So to me, the best practice is with the art line during exercise. You want to supplement that, Carl?
No, I completely agree with you. It was presented in meetings but never published. Was a guy that did all sorts of blood gases, after 5 seconds off exercise and 30 seconds off exercise and a minute and 2 minutes, and people renormalize within like 45 seconds. So if they they're all the way back to normal. The deficit has vaporized very quickly, and so that's why the A lines are so important. And we're fortunate. I know at the institution where you are currently, you can't get them to do this. They just flat out refuse in the pulmonary function lab, or at least they did for us when I was at the university. But in the Rural Clinic down at Cabin Creek, we have two respiratory therapists with incredibly good hands that put A lines in almost everybody without difficulty.
That's really cool, actually.
It is, and they do it. And the coolest thing is they do it with regular IV catheters. They numb first, and then they use regular IV catheters to put them in. So they've got the whole thing worked out to be efficient and quick. At the other hospital where I go, because an A line is in scope for respiratory therapists in West Virginia. Not in every state, but in West Virginia, that's in scope for respiratory therapists to do on their own. And so they do that. The other hospital I go to, they do the whole A line kit with wire, changing it over a wire and all that kind of stuff, which works. It's just it's more cumbersome. But the one clinic there, it's the techniques they use are incredibly equipment efficient. They just use a gel coat catheter in, put a little stopcock and a syringe, and what the fun part to me is that they tape down the top of the syringe, and then at exercise they just take the tape off and let it fill. It's pretty clever the way that they do it. I give them a lot of credit. It's really cool.
Yeah, and that's what Dr. Rasmussen started doing probably back in the mid or late 60s, and his studies were based on that methodology, which was part of the kind of revolution in understanding that he created.
Yeah. So I actually will know both what they could how much exercise they could demonstrate on the treadmill, what their peak exercise were. That's what we use is the peak. And then this is what you can do when you don't have a metabolic cart, which most people don't have access to, and DOL won't pay for. But the resting exercise ABGs is part of what you're supposed to do when you do a DOL exam. And so, so I have that way of estimating their exercise capacity. And this is now my spin on this is that their exercise ABG trumps everything else as far as their ability to do work. Because if they may have weird looking spirometry, but if they did 10 mets or 12 mets on the treadmill and their blood gases suggest they can support that, they probably have pretty good lungs. It's summative, whereas all the other testing is you're kind of looking at the elephant in different ways, but the exercise ABG kind of gives you I think the end result. If somebody gives me a metabolic card, I'd use it, but I don't have one of those yet. Any other questions or anything anybody else wanted to ask or add? I really appreciate that, Dr. Sansbury. That was great. Thank you.
This has been a really great discussion. We really appreciate all the comments and questions. And again, Dr. Werns, thank you so much for presenting.
That was great. Thank you.
Any final comments or questions before I go into announcements? Alrighty, well, thank you all so much. Thank you, Dr. Warrens. The only announcement I have is that our next session will be on August 15th, and Dr. Sangani will be presenting on antifibrotics and progressive fibrotic ILD. Keep an eye out for that reminder, and we hope to see you all next time, and I hope you all have a great week. Thank you, everyone.
Thank you, everyone. Have a great week.
Bye-bye.